Yeah. So, doctors, this is your first session with me, pediatrics first session.
Yes, ma'am. No, ma'am. This is my second session with you, ma'am. Pediatrics.
Yeah. So, I guess one student is new. So, I will tell topics of the pediatrics which you have to read. So, we have to read about newborn, each and everything about normal newborn, respiratory distress, jaundice. So, what all newborn problems you have to read it well. Secondly, you have to know a little bit of embryology, like what is urachus, what is midgut, foregut, hindgut, how it develops, what are the abnormalities. So, embryology is basically for congenital abnormalities. So, that is from your neonatology part. Next is what you should know, which separates the kids from adults. So, which property separates the children from adults? Anybody, can you guess? What is a different thing which the kids have, which we do not have? Which capacity which we don't have? Okay, so what I was telling, we have a special ability in the children, which is growth development. Okay, we see there is a growth development. It is individual property of a kids. Okay, so you have to know about growth development. So growth means increase in size of cells. So you can see in the form of increase in height, increase in weight, increase in head circumference. So yeah, so you should know the growth, that is the normal growth pattern, how it grows. So growth development, I hope you know. We are going to discuss it. Next is growth development nutrition. Okay. So for overall growth, require a good nutrition. The kids have a separate requirement of nutrition. So you should know about the nutrition, or you can diet part thoroughly. So growth development nutrition and vaccination, because they have a less immunity. How the immunity develops with recurrent infections, we got the antibodies against it and we got the immunity. So you get immunity with this. So yeah, so you should know about vaccination, which we say as a immune. We will discuss. So what is my pattern of teaching? I guess one student is already there. She will correlate. So what I do, I have prepared the slides from general topics which are very frequently asked. So they are questions and we will discuss a questions, okay? And that question have to listen whenever I am dictating that question. You have to read and understand about all four options, and whatever you think you have to reply. Okay, so you can reply in the check box. I will check your reply and we will discuss further. So this is just, you can say, your night practice session. So how fast you can reply, how you can think, because see, even though you have read everything in the exam, it is not necessary the question comes from your knowledge. Okay, so it is always a learning process. So I hope this sessions makes your learning process easier. Okay, so this is to make you self-learn. Yeah. So first question, generalized edema of newborn occur in all following except prematurity, non-immune hydrops, Turner syndrome, congenital nephrotic syndrome. So where there is not a generalized edema, except, they are asking about except. So everybody please try to reply. This is just practice session. We are not judging you based on these answers, but at least I can understand what you are knowing. Okay. So, yes, accept. They are asking accept. Okay. So, where do you not find? So, see, when there is a hypoproteinemia because of nutritional reason, liver failure, kidney failure, nephrotic syndrome. So, we know when there is the protein deficiency, albumin deficiency. So, all the water from the blood is going into the tissues because albumin protein is required to hold the protein in the blood. So when you have albumin deficiency or hypoalbuminemia, albumin deficiency is simply called as a hypoalbuminemia. So when you have a low albumin level, your the body starts swelling up, which is known as the edema. So yes, nephrotic syndrome, you will have a edema, generalized edema. Prematurity, they generally have hypoproteinemia. So obviously they will be having edema. Non-immune hydrops. Now hydrops. Anybody, what is hydrops? Do you know what is hydrops? You can type in the chat box. Regarding hydrops. Anything if you know regarding hydrops, please type chat box me yes. If you know something about hydrops, just say yes. We will anyway going to discuss in detail. But if you are not knowing, you can say just no. Good. Okay. Yeah. So hydrops is fetal finding. Okay. So you know the fetus is when the baby is in the mother's womb. Okay. It's a fetal stage. So this is edema of a fetal stage. Simply, it is edema before the birth, which is hydrops. Okay. So edema, how you can see? So on ultrasonography, there will be fluid in the peritoneal cavity, pericardial cavity, or there will be a pleural effusion. What it now? What are the causes of it? So if you remember, RH incompatibility, there starts hemolysis. Okay, if there is incompatibility between the blood groups of mother and child, I mean fetus, that happens very common in RH negative mother and RH positive mother, or O positive mother and AB or B positive fetus. Okay, so in that cases, the hemolysis starts. It is known as the HDN, hemolytic disease of newborn. So what happens if we have a hemolysis? We have a low hemoglobin. We will be having edema. So that edema is manifested in the antenatal sonography as a pericardial effusion, peritoneal effusion, or it's a pleural effusion. Okay, so that effusion is known as a hydrops. Okay, now depending upon the cause, like this was immune mediated hydrops fetalis, so that is called as the immune hydrops fetalis. Some infections, especially syphilis, parvovirus infection, they leads to such edema, so that is called as a non-immune hydrops. Okay, so that is again a edema condition, generalized edema condition. So that causes edema. So third option C is Turner syndrome. So if you see the features of Turner syndrome, there is a dorsum edema. So edema at the back of hand foot. Why it is happening? Because it is local lymphatic malformation. See, Turner syndrome. Syndrome is having multiple issues, multiple malformation. So lymphatics are not proper. That is a malformation. Got it? So answer here is Turner syndrome. Why? Because they have a edema, but it is a localized edema. They are asking for generalized edema. Okay. Which of the following falls regarding chest X-ray in a transient tachypnea of newborn? Prominent pulmonary markings, fluid in intralobar fissure, over-aeration, flat diaphragm, or diffuse reticulogranular pattern. So what is TTN, transient tachypnea of newborn? So, yeah. So let us see what is TTN, transient tachypnea of newborn. So I hope you know transient. That means it's temporary. It's just for some time. Tachypnea is fast breathing. Newborn. So it is in the newborn phase. Okay. So TTN, transient tachypnea of newborn. So there is something which is temporary and that is not serious. Okay. So what you see here is, this is generally seen in the kids who are cesarean born, okay, who are born by a C-section. They have a fluid accumulation in the lungs. Why? Because whenever there is a normal delivery, the baby passes through a narrow birth canal and that squeezes the body of the baby. So whatever amniotic fluid which was in the lungs, it is squeezed out in the normal delivery. But if we go for C-section delivery, we bypass that process. The baby doesn't has to pass through birth canal. We move the baby in the uterus only. So the chest is not squeezed, so fluid is filled. Okay. What you get is fluid everywhere in the lung. So yes, you will get fluid in intralungs fissure. The pulmonary vessel is dilated. So you get a prominent pulmonary vascular marking. You get a over aeration, flat diaphragm. Now these both are C and D options. These both are because of hyperventilation. Okay. So you are trying to remove that, like that means newborn is trying to remove that excess water by hyperventilating. That's why you get a over radiation also, you get a flat diaphragm also. What you will not get is diffuse reticuloglandular pattern, which is typical of HMD or hyaline membrane disease, which is seen in newborn. Okay, so transient tachypnea of newborn, they do not have a reticuloglandular pattern or hypoaeration, or they do not have a air bronchogram. They have a fluid collections and they have a hyperinflation feature. Okay. Now, so till now we were just seeing the fact-based question. Now we are discussing some case-based question. So this is the question where 3 years old child, male child, presented with loose motion 5 days back. Okay. On the second day of loose motion, the child has passed the blood along with stool, which he continued to pass till loose motion subsided. On fourth day of illnesses, loose motion stopped, but also developed oliguria. Patient becomes irritable, not pass urine for 24 hours. On examination, pallor is there, petechiae is there, hepatomegaly is there, tachypnea is there, edema is there, BP is 100/60. So what is the causative organism here? Is it E. coli, Entamoeba histolytica, Klebsiella, or it's a Shigella? So first of all, is the situation. This is some dysentery-like picture, loose motion with blood. Then it stopped and there is some kidney related issue. The child is not passing the urine. There is oliguria. Okay. Along with that, there is a pallor, petechiae also. Hepatosplenomegaly is there. So what is the thing? Like kidney is affected after dysentery. So what is this called as?
Oh, this is hemolytic uremic syndrome, ma'am.
Yeah, so this is a hemolytic uremic syndrome, which is sometimes you see after dysentery. Okay, very few cases, but very serious condition. Hemolysis is ongoing. That's why you get a pallor, you get a dark urine, you get a oliguria, and you get a hepatosplenomegaly again. There is a thrombocytopenia because of the rapid, fast growing hemolysis. So this is the case of hemolytic uremia. Because of kidney failure, you get a uremia. So this is hemolytic uremic syndrome, which happens after some strains of E. coli. Okay, so this is seen after enterohemorrhagic strain of E. coli bacteria. So the general features are involving kidney and hemolysis. Okay. Again, we are starting with this question. This is a 14 years old child presented with pain in abdomen for past 10 days. She has developed the vomit loose motion for past 4 days. Again, there is a complaint of both limb weakness. Okay. Unable to walk for 24 hours. On examination, patient is hypertensive. There is tachycardia, poor tone in both lower limbs, power grade 2 in both lower limbs. DTR are not elicitable. Which of this is not a differential diagnosis? GBS, acute intermittent porphyria, hypokalemia, Brown-Sequard syndrome. So tell me. which is not a differential diagnosis? Anyone? Okay. So see, this is a case of CNS manifestation. There is lower limb weakness. You have a absent deep tendon reflexes. So whenever when you have a lower motor neuron type of presentation, a specific finding is deep tendon reflexes is not elicitable. So what you first think is GBS, Guillain-Barré syndrome. So your first diagnosis will be Guillain-Barré syndrome because you can treat it via intravenous immunoglobulin. But if it is not the thing, then it could be acute intermittent porphyria, where again you get a such picture. There would be a hypokalemia. So if it's a diarrhea leading to hypokalemia, you will see the such condition. What is Brown-Sequard syndrome? Anybody?
Ma'am, hemisection of the spinal cord.
Yeah, so because there is a hemisection, so you will get a opposite side symptoms. Okay, so pain temperature fibers are crossing, so you get a opposite side loss of pain temperature, same side muscle weakness. But here it is bilateral symmetrical lower limb weakness, so that is again not there in the Brown-Sequard syndrome. So they are asking which of this is not differential diagnosis. So obviously hemisection of spinal cord, you get a half of the symptom on one side, half of the symptoms on the other side. Got it?
Ma'am, sorry, ma'am. What is the answer, ma'am?
Answer is D.
Okay, ma'am. Thank you, ma'am.
They are asking about which is not a differential diagnosis. So commonest thing we think is a GBS, but hypokalemia again can present as a bilateral lower limb weakness. So that is again the one of the DDs. Another DD is your acute intermittent porphyria, which is although very rare. But yeah, they also present with a bilateral lower limb weakness, especially aggravated by some symptoms of diarrhea, vomiting. So three differential diagnosis, which is not is a Brown-Sequard syndrome, because there you get a hemiplegia, half side of the body is affected. Okay. Again, a new question. You have a 15 years old male presented with pain in abdomen for past 25 days. Acute intermittent periumbilical. Also developed swelling of scrotum. Okay. 6 days back, which subsided within 24 hours. Past 2 days, patient is having pain over the right wrist with swelling of right knee. Patient also developed rash over the gluteal area. Patient is passing red stool. Per abdomen examination showed empty right iliac quadrant or right lower quadrant is empty. What complication this child has? Intussusception, intestinal perforation, volvular superior mesenteric artery syndrome. Tell me. Just guesses. Whatever you think, just have some guesses. Diagnosis. Could you make out some diagnosis? Think something. See, this case is acute intermittent porphyria. This is the picture of a rash. This is an X-ray. Okay. So this is intussusception and the case is HSP, Henocholian purpura. So what is happening here? Okay, can you see the rashes? So it is involving skin. There is a history of some loose stools vomiting. So that is GI tract. and there can be some kidney involvement. So this is multi-system involvement vasculitis, small vessel vasculitis. The name is HSP. Okay. It is a triad of abdominal pain, purpura, and arthritis. The purpura in the small intestine will work as a leading point for intussusception. Okay. Okay. Hypertrophic cardiomegaly, hypertrophic cardiomyopathy is recognized with infant of diabetic mother, Marfan syndrome, Williams syndrome, trisomy 21, which is Down syndrome, or Turner syndrome. Tell me. Tell me. Okay, infant of diabetic mother, correct answer. Because Marfan is associated with some that is either aortic dissection, aortic dilatation, aortic valve regurgitation, and prolapse. Okay. Williams syndrome, which is associated with pulmonary stenosis. Okay. Trisomy 21, it is associated with VSD, ASD, PDA. Okay. And Down syndrome, it is associated with Down syndrome. It is associated with endocardial cushion defect. Okay. Got it? Everybody is clear till now?
Yes, ma'am.
Okay. Now this is a newborn case. One day, one day a newborn is found to have a episode of apnea and syndrome. Patient target saturation is around 80 to 85. On crying, the saturation improves up to 100%. During the feeding, the baby becomes fuzzy and choking episode starts. So best step of management: oxygen supplementation, insert a nasopharyngeal airway, insert a oral airway, or insert a tracheostomy tube. Tell me what you will do for this case.
Ma'am, is this a case of tracheoesophageal fistula, ma'am? I do not understand what the diagnosis is.
Yeah, everybody please try to diagnose this first. Then only you will be able to answer. So can you see the child is having, as the child is comfortable, mild distress is there, but the saturation is very low, 80 to 85. However, the saturation improves on crying. Okay. And the baby becomes fuzzy while feeding. So can you notice when the child is crying, their mouth is wide open. Okay. So this is the case of not tracheoesophageal fistula. It is a case of choanal atresia. So what is choana? It is the membrane behind the nasal passages. Okay. So they cannot breathe through nose. They are breathing through mouth. Okay. So they are breathing through mouth. So that's why you have to keep their mouth open. That's why whenever they are crying, their saturation is improving on crying. So that's why they are in the stage of chronic hypoxia. So you can insert the nasopharyngeal airway and the child has a proper sleep. Correct?
Okay, ma'am.
Okay. Next question. Just a second. Again, this is a 12 years old girl presented with recurrent rash for past 3 years. She had an episodes of lip and tongue swelling that last for 3 days. Family history of similar symptoms in the father. which the medicine used for them is the prophylactic treatment for this cause of abnormality. So diagnose the condition and what you will give for prophylaxis. Diphenylhydramine, captopril, plasma-derived C1 concentration inhibitors, or intramuscular epinephrine. So first tell me what is this situation and how to deal with it.
Is this some kind of angioedema, ma'am?
Yeah, it is known as a hereditary angioedema. So hereditary means their father is having same symptoms. There is a swelling of face, swelling of lips and tongue. Okay. So it's a hereditary angioedema. Correct?
Yes, ma'am.
Okay. So what is the problem in the hereditary angioedema? There is genetic, means it is inherited condition. It's a genetic deficiency of C1 complementary inhibitors. Okay. So what happens? There is a inhibitor deficiency. So complementary system works like uninhibited and it keeps on firing. Okay. So we are checking or we are controlling this thing. Okay, the complementary system does not goes you can say unregulated. Whenever your complementary system is unregulated, it can destroy the normal tissues also. So that's why that edema happens. So as a treatment, or what was the deficiency? Complementary inhibitor was deficient. So that is recombinant available in the market. So you can give it as a prophylaxis. So it will protect the future effects. Got my point?
Ma'am.
Okay. So now next question. So these are some bit lengthy question with some difficult questions. So you have to read it carefully. First, make the diagnosis. See, there are two types. There, the two steps are involved here. Like they have asked, this is symptoms, what you will treat or what you will give for prophylaxis, like what investigations you go. So first, you have to diagnose in your mind what is the situation, and then only jump for the management treatment or prophylaxis. So again, this is a 2-month-old child, infant, presents to your hospital for healthcare visit. On examination, you note there is a disproportionate small stretcher with proximal shortening of arms and legs, trident hands, hypotonia, large head, frontal bossing, midfacial hypoplasia. You suspect some skeletal dysplasia. Which of the following will increase the risk of death? Craniocervical junction compression, hydrocephalus, obstructive sleep apnea, or lumbar spinal stenosis. So first diagnose it. What you are assuming?
It's a case of achondroplasia, ma'am.
Yeah, correct. So what is the commonest complications with achondroplasia? So they have a big head. Okay. If you compare it with limbs and trunk, the head is disproportionately large, or you can say disproportionately wide. So what do you mean by disproportionate short stretcher? That means this disproportionate. So short stretcher is there, but head is large. Okay, so head is, so suppose if we think about short stretcher, everything should be short. Here the limbs are short, trunk is normal, head is large, so you do not have the body proportions maintained. So this is disproportionate short stretcher. I hope you got my point. So this is a commonest skeletal dysplasia. Why it is not in the proportion? Because of skeletal dysplasia. Dysplasia means not proper development. So their limbs are not properly developed. That's why they are short. Okay. So I hope it makes the sense. Yeah. So what I wanted to say, that trunk is normal, but the head is large. Okay. So everybody knows we have a cervical spine, which is very critical area. Why? Because we have a respiratory center. We have a medulla lying there. It's a part of brainstem which has a respiratory center. So anytime if a compression on the medulla, it is always a life-threatening. Got my point? So here you
Yes,
have a
ma'am.
high chance of cervical compression at the foramen magnum where it is very near to the medulla. Okay, so that's why we are worried here. So all the cases of achondroplasia, they have to frequent go for this. Like they have to frequently go for CT scan to see the level of compression at the C1, C2, that is first and second cervical spine. So because most of them they have a sudden deaths. Okay, when their head grows significantly, there will be sudden compressions and sudden respiratory arrest and sudden death. Okay, so to prevent that, you frequently go for scans, and these are the level of compressions. Again, this is the 8 years old boy. So now we are jumping for endocrinology. So there is type 1 diabetes mellitus, which was diagnosed 2 years ago. So means at the age of 6 years, the baby boy had a diabetes mellitus. They are now just coming for follow-up visit. Review of system is significant for increased fatigue and constipation. So what is the problem here is fatigue and constipation. But he is otherwise doing well. The boy's physical examination is significant for height that has dropped from 10th centile last year to less than 3rd centile this year. So there is some short stretcher. His examination is otherwise normal. No goiter, no skin changes, no abnormal findings at injection sites. HbA1c is 6.9. So what is the cause of poor growth here? So see, it's an autoimmune condition. So this is, if you know, like there are two types of diabetes. Type 1 is insulin dependent, which we commonly as a pediatrician see commonly. So there is a destruction, or it's an autoimmune situation where the pancreatic B cells are destroyed. So there is permanent destruction by autoimmunity. So you have to replace it. Second is seen in some older people, which is insulin resistance type of diabetes, where you have insulin in situ in the body, but it is not working on the receptors. So you are feeling there is the insulin deficiency, but actually insulin is there. So that is insulin. That is your insulin resistance diabetes, where you give a other oral hypoglycemic agents. So this is a case of types is more likely autoimmune situation. Now, as it is happened, we are more worried for the growth, okay? Because any chronic disorder, so if it is in adults, they have reached up to their maximum growth potential. But when I say about it's in the growing age, we are worried for the growth of the child. Sugars are not well maintained. This child soon at the age of 13-14 years, he or she will hit the puberty. They have their growth spurts. So if any chronic condition is ongoing, all this is affected. So I have to control all these things. So if I see for this case, they have just a complaint of increased fatigue and constipation. Okay, so some GI complaint is there, fatigue is there, which is generalized complaint, and some short stretcher is there. Okay, now what we think, this is the diabetes which is not controlled and which has lead to height issues. So this is our first impression. So they have given HbA1c value. Can you see?
Yes, ma'am.
So it is not that much high. Okay. If I say HbA1c is not controlled, that means it could be around, you can say 12, 15. In such situation, we get a case which is having height affection. Long time sugar is not controlled, then we can get such results. So that is again out of the picture. So sugar is not the reason for growth failure here. Now we have two situations. Either it could be another autoimmune disease. The commonest autoimmune disease with diabetes is hypothyroidism, that is Hashimoto's thyroiditis. Second is celiac disease, okay? And the third one is a pernicious anemia, okay? So it could be any of this. But what is the commonest is thyroid disorder. Because the child has the constipation, they have a short stretcher within 2 years, and there is some generalized fatigue. Okay, got my point?
Yes, ma'am.
Okay, if it is pernicious anemia, generally the height is not affected. They have a macrocytosis, they have anemia, B12 deficiency symptoms. Okay, if it is a celiac disease, it is diarrhea alternate with constipation. They have a more of a weight loss than height loss. Okay, height loss is also there, but more the complaint will be on the altered bowel pattern. Okay, so this case is thyroiditis and it is destructive. So you will not get a goiter. Goiter happens when there is a hypothyroidism. Okay, it's a hypothyroidism with TSH is high. Okay, so that case is it's a goiter. Correct?
Yes, ma'am.
Yeah, this is our next question. So this would be our last question. We will discuss this question and you have to read these topics. Whatever topics we have discussed, now you have to read it, revise it, and then we will discuss new topics tomorrow. Okay. You are called to see a full-term newborn who is found to have abdominal distension with delayed passage of stool, which was 20 hours after the birth. So normally, the stool passage should happen within the first 24 hours. Here it was delayed. The pregnancy was remarkable for diet control, gestational diabetes, and echogenic bowel on the second trimester sonography. The newborn has been breastfeeding well with good urine output, no passage of stool. Examination shows alert, active newborn with marked distended firm abdomen, externally patent rectum. So rectum is open. That means the anal opening is good. Okay, it's there. Got it?
Yes, ma'am.
So this is the situation and barium enema was done. So this is the picture here. Can you see? This is the picture here. I am zooming it out. This is barium enema picture of same newborn. What are your assumptions? Tell me. What is this classical looking picture? Can you tell this finding how this looks? I'm just zooming out. How it is looking like? This, this. Can you see some appearance here?
Yes, ma'am.
So it is soap and bubble appearance. Can you see? This is just like a bubbles of soap. No, it's not sausage sign. It is soap bubble. These are some bubble-like pictures within the bowel. Okay. So this is me. So what is the? So which of the following is likely reveal out the cause of the clinical and radiological findings in the newborn? Chromosomal analysis, sweat chloride test, rectal biopsy, or urine CMV cytomegalovirus culture. So again, they are not asking what is diagnosis. I told you it is meconium ileus, but in which condition you get it? Any idea, anyone?
Ma'am, in case of Hirschsprung's, and then in case of cystic fibrosis,
Yeah,
and
Hirschsprung is different. Hirschsprung, you get a transition, like you have a mega colon followed by very narrow colon. Okay, that is your Hirschsprung finding on barium enema. This is typical of soap bubble appearance. That means there is no water within the meconium. The meconium is insippated. That means it is very hard kind of. So that is causing soap bubble appearance. Okay.
Okay, ma'am.
So now what we were thinking of, that it is associated with cystic fibrosis. So what is the question here? How you will diagnose cystic fibrosis? Tell me.
Sweat chloride test.
Yeah. So answer here will be sweat chloride test. Got it? Anybody having any doubts? Fine.
Fine, ma'am.
Shall
Yes,
we
ma'am.
end the session now?
Yes, ma'am.
Okay. So tomorrow, I guess tomorrow is there or not there. Let's see. So in the next session, we will meet with the new topics and the new discussion.